is too high, too low, you're going to develop that same, anterior knee pain. But yes, obviously I see a lot of less of these problems that we're discussing in triathletes than any other runners. Is this a particular problem? Okay. Iliotibial band. I showed you exactly where. Oh, that's on the outside of the knee, it can cause anywhere from proximal hip pain all the way down to lateral knee pain. Whenever there's lateral knee pain, you're already thinking palpate the hip, and notoriously they're going to be just as painful at the proximal hip as well. Proximal lateral hip, that is. And it's usually exacerbated by running or cycling or hiking. Prolonged hill running can cause this, or running on the roads where the roads are sort of cantilevered to the outside. So you have one leg that's higher than the other. This can be even from running around the track in one direction too much, okay? And this occurs from repeated sliding over the lateral femoral condyle that I was showing you. Okay, next slide. Basically, you get tenderness along the outside of the knee, on the lateral knee. We do a test, a diagnostic test we call the Overuse test, having the patient lie on an unaffected side, hip rotated in, and you stress the leg internally, and you'll get reproducible pain along the lateral aspect of the leg. Next slide. The treatment or imaging is really not indicated. MRIs can show edema and inflammation, but you really don't. X-rays are usually normal. Basically, we work with hip adductor strengthening, stretching, icing, and NSAIDs. Cortisone injections, again, rarely, but we can do that sometimes. Cyclists undergoing evaluation, and again, making sure that runners have proper shoe fit and design. Next slide. This is shin splints, medial tibial stress syndrome, and basically it's a dull ache along the inner aspect posterior in your lower leg. You have focal tenderness. If you have usually the tenderness is going to be along the entire lower inner part of your lower leg. If you get focal tenderness, and the doctor will many times percuss or hit the bone like this, if you have focal tenderness, that's kind of a hint that this may be actually be a stress fracture and not an actual tendinitis. Usually the most common problem associated with this is hyperpronation. Next slide. Usually x-rays are normal. MRI bone scans are helpful if you suspect a stress fracture. These are patients who aren't getting better. That's what you would go to next if they haven't responded to rest, treatment, etc. Next slide. Many times we will have to use, as far as how we treat that, not much difference at the top, icing, rest, etc., stretching. Address the hyperpronation, either with insole or orthotics, and strengthening of the antagonistic muscles. And this is where doing the lower leg stabilizing muscles are helpful, strengthening the anterior tib, external, the foot everters are very helpful in battling this problem. But Matt will probably tell you that that's probably one area we don't address a lot, is that lower leg stabilizing types of exercises. Next slide. Okay. Achilles tendon, this is more common in the middle-aged group. An acute injury, or when it gets ruptured, is as if somebody kicked you in the back of the leg. Next one. Okay. Usually have tenderness along the Achilles tendon with some crepitance. Thompson's sign is a sign that we test if we think that the Achilles tendon is ruptured. And basically what we do is a simple test, is that when I squeeze my calf muscle, my foot actually plantar flexes slightly. If it doesn't move or doesn't plantar flex, that means you've ruptured the tendon. You can actually palpate many times, palpate the defect as well. Go ahead. Let's see. Again, x-rays are really not necessary. MRI is helpful if you suspect a rupture or partial disruption. Again, ultrasound, you can do it. Some doctors, I do ultrasound myself, so where I can diagnose it right there without MRI. Next slide. Let's see. Severe cases may require a walking boot. You can use heel lifts. Eccentric strength training is the cornerstone for this particular treatment. Next slide. This is just an example. Everyone probably knows what eccentric strength training is. is where you actually are strengthening the muscle by the muscle elongating as opposed to contracting. You're letting it elongate. So this is an example where you come to a calf raise with 2 feet and letting it down with one leg. And you can use weights as well. But in this particular condition, and as well as lateral epicondylitis, or the Cochrane database review has shown that these specific exercises are very good in treating this particular problem. Next slide. Okay, plantar fasciitis. Basically, this is pain in the heel or in the arch. Usually worse first thing in the morning you get out of bed. Usually after a warm-up it can get better, and it only returns and becomes stiff and sore after you stop the activity and relax, or after you rest for a while, then it comes back. Next. Like I said, usually tenderness along the sole of the foot, along the medial arch, along the heel as well. You have pain when you passively dorsiflex the foot as well as the toes. People who have flat feet or high arches, rigid subtalar joint are predisposing factors for these for developing plantar fasciitis. Next. Showing the spur is really non-diagnostic, meaning that half the people in here may actually have a spur, but it doesn't really mean that they have plantar fasciitis. Okay, so really, in the presence or absence of the spur does not mean anything. Okay, next slide. Again, ice massage. The best thing for this is ice massage. Usually I tell patients to get like a Dasani water bottle, freeze it while they're watching TV, just roll that on their arch and their heel. Sometimes you can use tension night splints. Interesting study this one came out last year as far as silicone inserts. Those have actually been more helpful than heel cups. Silicone inserts and heel cups actually are even more helpful than using custom orthotics. Usually tell patients not to try to avoid flat shoes, use a shoe with the heel, and not to run or use those little footy kind of shoes, or go barefoot. So it's good to have a little heel. Surgery can be done, but that's usually if they're not responding to treatment for 6 to 12 months. Okay, next slide. Okay, stretch fractures. This is basically, I talked about this actually last year, but this is basically when it's microtrauma on the bone and the bone cannot heal fast enough or before it's actually remodeled. Usually these patients have progressive pain, and it's pain over a bony structure. And it's worse with weight bearing. As the problem gets worse, you will start to develop pain at rest and not with activity. For me, usually a hallmark of a stress fracture is that they can run a certain distance, and then as their training progresses, the pain starts to increase or start at distances that get sooner and sooner. In other words, if it didn't start until 5 miles, and a week later it started at 2.5 miles, then 1 mile, and then at rest. That's really a hallmark for me of that they probably may have a stress fracture. We see it really more in long distance runners. Have a high suspicion for stress fractures. Next. Okay, usually you have focal tenderness over a bony prominence. Sometimes you'll have some soft tissue reaction, in other words, swelling and edema. That's usually a bad sign, but not a bad sign. This usually probably means that you have a clinical fracture. Usually with femoral stress fractures, you'll have the patient's usually walking with a limp, and you'll have pain with passive range of motion. Next slide. The trick in diagnosing this is that x-rays usually are negative, and they're not really positive until 4 weeks or even longer after. And there may be some hints or signs on the x-ray, cortical thickening, some reaction, periosteal reaction, but usually MRI and bone scan are the studies of tests. And usually we especially look at joints of high risk, like the femoral neck or the navicular. Why is the femoral neck and navicular so important? Usually because if these joints become fractured, you may actually disrupt the blood flow to that bone and make osteoporosis. So those are particular bones that we're really careful or we're more suspicious of getting that treated. Let's see, the last test is usually done for osteoporosis, so we use that for our female triad, females who are more high at risk for osteoporosis. We'll usually do, if we find a stress fracture, we'll do a study and follow up as well to make sure they're not osteoporotic and need additional treatment. Next slide. Okay. Again, relative rest. Treatment is really specialized or specific to the fracture. So if it's a metatarsal fracture, we'll usually give them a post-op shoe or a hard-soled shoe or walking boot or crutches. If you have fractures in the femoral neck, anterior tib, again, the navicular, that usually you need specialized care and treatment depending on what's going on. Again, you want to prevent avascular necrosis. So certain fractures need a specialist to really address. In military recruits, using shock-absorbing inserts help reduce the risk of metatarsal stress fractures. Next slide. This is a important syndrome that I want to talk about because, especially for the athletes and